Good afternoon, ladies and gentlemen. Our webinar is beginning. My name is Steve Love. I'm President and CEO here at the Dallas-Fort Worth Hospital Council, and we really appreciate you joining us today for this educational webinar. And it's hosted in coordination with hospital pricing specialists, and they're an associate member of the DFW Hospital Council. Today's topic: data-driven hospital pricing, aligning Chargemaster strategy with market and reimbursement realities. This really should be a great discussion. As you know, hospital price transparency has really changed the landscape. It began more as a compliance alternative or initiative, and now it has really changed and evolved into a strategic imperative that impacts reimbursement, negotiations, expectations. And this session is going to explore some of those approaches, including market-based pricing and reimbursement-informed pricing governance. Today, we're delighted we've got with us Randi Brantner, the Vice President of Operations at Hospital Pricing Specialist. I think some of you may remember she was a speaker at a webinar for us last year. And so we look forward to hearing her expertise on this topic. Before we begin, though, please take time as you have questions to either put them in the Q&A box or you can put them in the chat box. Either one. I'll be monitoring those and we'll try to answer those at the end of the webinar. So without further ado, it's my pleasure to now turn this over to Randi.
Thanks so much, Steve. Hello, everyone. Like Steve said, I'm Randi Brantner. I am the Vice President of Operations for HPS. I really appreciate you joining us today for data-driven hospital pricing, aligning Chargemaster strategy with market and reimbursement realities. So clear and accessible pricing information is really crucial for all of our healthcare providers navigating those high deductible plans. So our presentation today focuses on developing effective pricing strategies, including insights on enhancing price transparency, fostering competitiveness, and ensuring appropriate reimbursement. So our objectives today include outlining revenue stream pricing categories and associated considerations of those revenue streams. We're going to identify some effective pricing tactics for each of those revenue streams and develop a logical pricing methodology based on either cost analysis, reimbursement rate analysis, or pure pricing data. Now, ultimately, this presentation will arm you with the knowledge necessary to improve financial sustainability through strategic pricing, enhance patient satisfaction with transparent pricing, boost competitiveness, and ensure appropriate reimbursement. Now, I know that hospital pricing isn't for everyone. It is a very overwhelming subject. It's one that I'm very passionate about, and I hope to really bring some clarity by breaking down the Chargemaster into some manageable sections and introducing pricing approaches for each of those areas. A little about HPS. So Hospital Pricing Specialists, or HPS, we bring over a century of collective experience in Chargemaster management, healthcare pricing, reimbursement, and payer analytics. Our leadership team here has successfully completed over 1,200 pricing projects for hundreds of clients across the country, from critical access hospitals to large healthcare systems with several thousand beds. We excel at enhancing hospital revenue cycles, and our deep knowledge and extensive experience make us a reliable partner in navigating the complexities of healthcare pricing and price transparency. All right, so let's dive right into our topic for today. First, I'll talk a little bit about pricing and the hospital revenue streams. Now, hospital charges are intended to represent the statistical basis of cost for hospitals. And although all hospitals are reimbursed differently according to their OPPS or critical access hospital status, and obviously our other third payer party contracts, Blue Cross, Blue Shield, things like that, we still see our charges themselves divided into these basic revenue streams. Now, our revenue streams include observation and room rate charges, emergency room and clinical services, so think chemotherapy, wound care, hospital-based clinical services, and then your CPT HCPCS code procedures. Think about the diagnostic and therapeutic services really common in radiology, laboratory, and rehab. Operating room services, so those are going to cover your technical anesthesia, your hospital component of that anesthesia service. Operating room, again, we're talking about the hospital side of the operating room. Recovery and PACU services. Pharmacy products, again, we're looking at the product itself, not the nursing administration. And then the medical supplies, so your medical supply products themselves. Now, professional fees are also another revenue stream that I don't have on our chart here. But the variability in how facilities handle professional fee billing merits kind of a separate discussion, whether they do or do not bill, whether they employ the professionals, things like that. So we're not going to discuss that today. Our discussion today will be focused on the hospital side of charges. But if you have questions about pro fee billing, please contact me directly. Now, we all know when new charges are created, many revenue cycle professionals will look at the Medicare OPPS fee schedule to develop their pricing. This is a preferred method because Medicare payment rates are intended to represent the cost of providing the service. So even if you're a critical access hospital, using that OPPS fee schedule is an appropriate pricing strategy. As I mentioned before, hospital charges are intended to represent that statistical basis of cost for hospitals. Therefore, some facilities will perform studies of capital, supplies, staffing, or other resources to develop pricing in other areas. Now, sometimes this does require some significant pro forma work, but performing a capital study such as this does help to ensure that pricing is appropriate according to your cost and resource utilization. But in reality, in the long term, this strategy can become cumbersome and hard to manage. Now, most pricing vendors like ours compare our facilities charges to peer hospitals reported in the Medicare claims data. Now, here at HPS, we use the inpatient and outpatient standard analytic file published by CMS, which includes adjudicated claims to Medicare. This gives our clients access to hospital charge data for every reportable charge in the hospital. This includes inpatient, outpatient, and ASCs that all report on a UB04. Now, Medicare data is the most accurate and comprehensive source for comparing charges between hospitals because almost all U.S. hospitals participate in Medicare, and hospitals are required to charge the same price for the same service regardless of the patient's insurance payer. Now, Medicare publishes this data frequently. It is readily available and an accurate source of our peer group data. Now, throughout today's presentation, I'll actually be demonstrating actual market data from 2025 quarter 3 for the Dallas-Fort Worth area hospitals and the state average. Now, don't have a heart attack. Everything has been de-identified in the presentation, but I will allow you guys to kind of see how the market looks in your area, and we'll dig into that information shortly. Although these three primary strategies, reimbursement-based, cost-based, and market-based, are the main go-tos for hospitals, many facilities will actually use a combination of these strategies according to different revenue streams. So I'll walk through those combinations very soon, but I wanted to take a moment to talk about ongoing maintenance of pricing. I know many hospitals have traditionally implemented a uniform annual price increase year over year, and this method was sufficient prior to the era of price transparency. This practice involves raising all service prices by a set percentage each year without considering market conditions, reimbursement methodologies, or competitor pricing. Now, with the advent of price transparency, we're now 5 years into it. That's so hard to believe. Many stakeholders, including consumers, the press, researchers, now have access to this detailed pricing information. This shift has significant implications for hospitals that have previously relied on those uniform pricing increases year over year. Specifically, if a service was priced high a decade ago, we have now compounded the price of that year over year, which really can result in public scrutiny and a risk to the hospital's reputation. This new environment necessitates a strategic approach to pricing. Hospitals should consider the market data to really make those informed decisions about which prices to adjust and how much to adjust them. Now, some prices might need to be increased, while others should be lowered to really remain competitive and avoid the pitfalls of price transparency. Adapting to this approach will help hospitals align their pricing strategies with market expectations and mitigate the risk of negative perceptions to the hospital. Now, let's start applying those various strategies I discussed across different revenue streams. Now, daily hospital services like observation, room rates, those are used to represent all routine nursing and facility resources. Because of this, reimbursement for room rates is generally incorporated into whether it's a per diem rate or DRG reimbursement and should be priced according to the peer group, if at all possible. Otherwise, the hospital could do a study of capital, supplies, staffing, other resources to determine a price for room rates. Now, this does require significant work. Performing a capital study like this does help ensure that pricing is appropriate according to actual resource utilization. Many hospitals, though, in my experience, do not see inpatient room rate charges as much of an issue with regard to patient satisfaction. And this is because your insurance payers generally collect the same deductible, co-insurance, and co-payments, regardless of how much the room rates themselves are. Now, hourly observation reimbursement differs by payer, so you're going to see case rates, percent of charges, and fee schedules for those hourly room charges. We recommend that the hourly charges be priced at 1/24th of the daily room rate whenever possible, but we do see some facilities use a front-loaded first hour and lower second to 24-hour charges. Again, the 24 hours of observation should be equal to the daily room rate. As I mentioned before, I'll be showing various market data comparisons as we go through this presentation today. This data includes hospitals located within the Dallas-Fort Worth area, as well as the Texas state average for 2025 Q3 Medicare claims data. This particular screenshot is a sample of observation hourly charges in the Medicare data. So that would be G0463 with revenue code 762. Now, this data allows the user to determine the reasonableness of charges compared to its peers using this code combination. In our example here, Hospital 22 is at the top of the market with $338 per hour. That's over $8,000 per day. Meanwhile, the Dallas-Fort Worth market average is around $168, so a little over $4,000 per day. So from a market perspective, Hospital 5 and 6 have plenty of room to increase this charge to get to the market average, but Hospital 22 is really pulling up that market average. Either way, we still want to ensure whatever pricing decision is made that the observation charge does represent 1/24th of the daily room rate. All right, so moving on to emergency and clinic visits. So emergency room visits are reported under the code set listed here, 9928 series. Pricing these charges at a multiple of Medicare reimbursement or the average of the peer group is our recommended practice. Now, the clinic codes are reported under G0463. And for those of us who've been in healthcare for a while, we know that previously that code was broken out into acuity, new, and established-based codes, which I have listed here as well. Now, the code change obviously simplified our billing process, but when it comes to pricing, it does present a challenge when we're trying to set those prices based on acuity. And this is because some managed care payers still accept those 99201 or 99211 codes, those detailed levels. So it means that we still need to create charges based on acuity. So we recommend pricing at either a multiple of the Medicare reimbursement or the average of the peer group adjusted for that acuity. As an example, I would probably set the mid-level visit of an established patient for G0463 at the peer average, and then price higher or lower acuity charges above and below that mid-level rate. Meanwhile, ensuring all of it is above all of your reimbursement amounts, your fee schedules. So when we look at that sample data for the Dallas-Fort Worth Hospital area, we are looking at 99283. This is our mid-level ED visit with revenue code 450. We're looking at the average for the Dallas-Fort Worth group to be around $1,605 per visit. Hospital 17 is almost twice that of the market average, and hospital 26 is approximately half of the market average. Now, I will note when I see this much variation in a peer group, it could mean that these hospitals are not a relevant competitor of one another. Usually in this area, it's because of a trauma designation, right? Hospital 17 might have a very high level of trauma, whereas Hospital 26 might be a critical access hospital or something along those lines. All right. Moving on, diagnostic and therapeutic procedures. Now, these procedures are assigned specific CPT HCPCS codes, which is great for us because this data is very, very clear in the Medicare claims data. Now, our reimbursement will vary by payer. You're going to see things like case rates, fee schedules, percent of charges. But as a rule, we still like to see either multiple Medicare reimbursement or the average of that peer group pricing data. Now, the exception to this rule are items that have common patient satisfaction issues, right? If you are always getting a phone call on this one CT, maybe you need to dig into that one just a little deeper to see what you can do to be a little bit more retail oriented. So common areas for those price pressure are things like lab, CT or MRI, mammography, rehab. These should be looked at and priced competitively against other data sources. So think freestanding laboratory like LabCorp or Quest, or radiology centers, those freestanding radiology centers. So this allows our charges to be a little bit more comfortable to communicate. And again, getting us a little bit more into that retail-oriented mindset for these types of procedures. When we look at the sample data set for 85025, so that's a common lab procedure, a CBC, this data is interesting because reimbursement for this code is, for Medicare anyway, is packaged to most APCs, or it's actually less than $8 on a lab-only claim. But as you can see, the peer prices for this HCPCS code range from $14 to $298, with the average hovering around that $195, which, if you do the quick math, that's 24 times the Medicare reimbursement. Now, as we saw on the previous slide, we could price this charge at a multiple of reimbursement or the pure market average. In this example, though, pricing that charge at 3 times Medicare would put the charge well below the peer group average of $195, right? So targeting the peer average might help to improve our commercial payer reimbursement if your commercial payers are reimbursing at that level, while still remaining within that market average, that price transparent, so to speak, market average. Again, the conversation still needs to be had, is 24 times Medicare reimbursement and an appropriate calculation? And I think at some point we look at this and say, we're well beyond that conversation, right? But again, making sure that you're above your managed care fee schedules, especially those that have lesser of language, which we'll talk about in a bit, is really, really important in this scenario. Moving on, we're going to dig into the OR. So there's several components of surgery, which I talked about earlier, the OR, the anesthesia, and recovery. Again, we're focused on the hospital side of the charges. Now, the operating room charges represent the hospital component of the OR service provided. So that's the setup of the room, the staffing, any sort of special or rental equipment associated with that. Now, hospitals can set up charges based on individual procedures or create acuity time-based charges according to staffing costs and additional equipment charges. Time charges are determined according to the start and stop time in that surgical record, so wheels in, wheels out. The use of special or rental equipment should be captured by bumping that procedure to a higher level. So let me show you. I know that was a little bit of extra information, but a visual is always helpful. So this is a sample of a leveling tool that illustrates how an acuity level could be determined and then priced. So for example, if a procedure with less than 30 minutes of setup would follow the left-hand branch of our tree here. As we continue on, if that procedure has no additional staff or no additional equipment or rental equipment, it would result in a level 1, which is our low acuity surgical level. This charge would then be set up with a front-loaded initial time frame, let's say 15 or 30 minutes, and then additional 15-minute increments. On the other hand, if we have a procedure that has more than 30 minutes of setup, hasn't that additional staff member in the room, for monitoring purposes has a special rental equipment, that would bump us up to a level 3 procedure. Obviously, depending on your facility, this tree could be less or more complex as what is needed. This is just kind of a general example. But the main issue is this acuity leveling methodology really allows the facility to account for the resources for a normal procedure, and then using those additional time increments to allow to capture more complex cases or resource utilization, or if something goes sideways, we have to bring in more or do more, spend more time with that patient. We are increasing that charge because those costs have increased. Now, reimbursement in the OR is usually included kind of in a packaged set. So you're going to have kind of a package reimbursement for surgical. So we really don't see in the market data the capability to price the levels according to market, because we can't see in the CMS data, okay, this is the level 1 charge, this is their level 2. We can't make that sort of comparison. So we actually have to take a step back and look at the Medicare data from the revenue code level. So we'll look at the 360 revenue code and make a comparison across the market to determine what their pricing looks like in the OR suite. So let's take a look at that real quick. Oh, wait, before I do. If you decide to still use the procedure-based surgical charges, you can. This leveling methodology obviously would not apply. You could use it to obviously price the first time or whatever it is. But procedure-based charges would be priced according to the peer pricing data. So if you've got a screening colonoscopy that you're looking to price, you can price that at a procedure-based level. That helps you keep an eye on price transparency to keep that procedure pretty regular, because we're not going to see a lot of variation in that type of procedure. So it is okay to keep that as a procedure-based charge. Moving on. So this, again, if a facility is using a time-based or acuity-based operating room charging methodologies, we look at that market opportunity at the revenue code level. So this slide illustrates what the 360 revenue code looks like in our demonstration environment. This allows us to evaluate the revenue stream, again, at that higher level, that 30,000 foot level, which gives us insight on also to the severity of the cases performed. So when we look at this data, it seems shocking when you first look at it, but when you dig in, the facilities with those higher charges in this area perform obviously more acute procedures. We're looking at hearts, prostate removals, kidney removal, hernia repair, hysterectomies that other facilities are not performing. The facilities on the lower end of this range are performing much less acute procedures. Now, if we find that a hospital performs less acute procedures, let's say I'm working with a hospital that's, I don't know, hospital 4 on this screen. They're further on the right end of this graph, right? If I'm working with them, I'm going to probably kick out the top 4 on this graph, top 5 maybe, as not relevant peers for them based on the procedures that they're performing. So just something to keep in mind when you're deciding who to compare your charges against. Now, in this case, we're looking at that procedure level base. In this case, this is the removal of a cataract. So when we look at this market data, again, pretty clear market data in here, we can see how these hospitals compare. Hospital 1, extremely low compared to its peers. Again, really just focusing on that 360 revenue code and the 66984. Hospital 3 charges over $19,000 for this procedure, and our average in the market is around $11,000. So technical anesthesia. So again, this is that hospital component of anesthesia administration. Managed care contracts generally do not allow the reporting of both itemized and time-based anesthesia. So when you are looking at your anesthesia charges, keep in mind what of those are going to be time-based and what are one-time charges. We have those kind of rolled up here on the screen. We recommend creating charges based on the anesthesia time where applicable, especially when it comes to general, the MAC monitored anesthesia, and the moderate sedation. Now, this again will be based on the start and stop time, wheels in, wheels out in the patient record. Because reimbursement for technical anesthesia is included in that overall surgical reimbursement package for Medicare, the information, again, is elusive in that Medicare claims data. We, again, look at that revenue code level to price that. We like to work with hospitals to make sure that the pricing reflects that resource utilization in those time-based increments where we can, or those one-time charges. Now, others sometimes roll anesthesia into the case rate or the surgical grouper, but some will apply percent of charge reimbursement to this area. Same kind of story for recovery and PACU. So general anesthesia usually requires at least 1 hour of one-on-one recovery care. So once that patient is attended to for that minimum period and the nurse says they're good to move to a lower staffing ratio, the nurse can then attend to 2 patients. Pediatric patients usually going to have that one-on-one for the entire recovery period, depending on the procedure. Many facilities will create kind of an initial 1 hour front-loaded charge and then have additional 15-minute incremental charges if you're having a hard time bringing somebody out, right? We want to be able to account for that extended time spent with that patient. Now, some hospitals will also charge by the minute, and that's perfectly fine as well. There's no really billing guidance on that, right? As long as you have a defensible way to charge your anesthesia recovery, you're good to go. Now, from a Medicare perspective, reimbursement in this area is included in that surgical package. So we really don't have the ability to price those individual charges or see that data to say, okay, this is the anesthesia for this procedure. But we do like to see that nursing and facility resource utilization accounted for, keeping in mind that the reimbursement methodologies for other payers are going to be things like percent of charge and case rates. Now, another consideration that has to be made for that OR service line as a whole, again, including the OR level recovery anesthesia, relates to each facility's use of bundling those charges. So as you can see in our Kate rate analysis for 43239, it's an endoscopy. Our demo hospital doesn't regularly bill recovery charges separately. They only bill it 34% of the time. Meanwhile, Big Health Facility does bill recovery separately 100% of the time. So when we're looking at the market data, we have to keep this in mind because you're going to see some different price comparisons in this information. Now, anesthesia in this case is billed 100%. In this case, is 100% of the time at both facilities. So really understanding how your competitors are charging for those services really allows us to have some additional insight on how your pricing actually compares in this service line. Checking my time. Okay, let's talk a little bit about pharmacy charges. So drugs dispensed in the hospital setting can really become a sensitive area for patients, right? We all know about the $300 Tylenol. And this is because the patient has the ability to compare these prices against what they pay in their local retail pharmacy. Coming from a pharmacy background, it's frustrating, I know, but this is how a patient thinks. So the recommended practice is obviously to create a cost-based markup with a fixed add-on or minimum charges to kind of compensate for the departmental resources involved in storing, handling, and preparing items. Now, fixed add-on charges are used to represent the time and resources associated with preparing and handling medications. To determine that fixed add-on, we take into account things like the route of administration, the staff skill level, the preparation time that should be considered. The route of administration refers to how the medication is administered. So IV compounded medications are going to require more resources for preparation than an oral tablet, right? I'm pulling an oral tablet out of a dispense machine, or I am in the hood building an IV, right? Those are very different workflows. So the fixed add-on fee would be appropriate for that work in the hood, that IV route. We're talking about the skill level, the preparation time, and the required training for that. So for example, a chemo IV, you have to go through additional training and skill for that. You have a special hood for that requires different inspections and maintenance, obviously for both of them. So those categories of drugs are going to be a higher add-on fee. Now, keeping in mind also the preparation time, it takes a while to compound, to dilute a medication before putting it into an IV bag, and any sort of outsourcing or handling costs that are associated with certain drugs. And then finally, we recommend a separate markup for items considered self-administered. So this concept refers to the self-administered drugs. It's interesting. So Medicare defines self-administered drugs that are administered by the patient 50% of the time in its overall use in all settings. So even though a patient may not administer the topical medication to her or himself during the stay, since it could be administered by the patient most of the time in all the other settings, it is considered self-administered, meaning it cannot be billed to Medicare. So for self-administered drugs, we recommend assigning those lower multipliers and minimum charges to keep those charges low. And that really lessens the impact of the patient responsibility or hospital write-offs, depending on that process. Now, the market data for areas like pharmacy and supplies should not be analyzed at the CPT HCPCS code level. And that's because CPT HCPCS codes can be used across items that have different cost bases in the markups. But the market data allows us to review the market position, again, backing up to that revenue code level, just like we saw in the OR services area. This screenshot is focused on the 250, 636, and 637 revenue codes to demonstrate the average across the entire revenue stream. Again, depending on the services provided at that hospital, these values are going to swing quite a bit. It's likely that Hospital 1, just kind of eyeballing this, Hospital 1 likely has a high chemo service line. That Hospital 28 down there at $13 does not. So again, pharmacy charges, we're really going to use that markup of cost, but reviewing the markup or the market ensures that you're aware of areas that might be putting you on the front page of the news. Cruising along, we're going to look at supplies real quick. So like pharmacy, medical supplies are priced according to that cost-based markup. Well, should be. Items with lower cost are generally assigned higher multipliers, and higher cost items are assigned lower multipliers. We recommend using the actual cost basis to price medical supplies, but many facilities will actually employ the use of a cost threshold for low cost items. Basically, that sets a rule that they won't charge for items under a certain cost. Now, that cost threshold varies according to the facility, but it can be $5 to $25. It just kind of depends on the value that hospital has in mind. And setting that minimum cost threshold is what is considered billable, reduces the effort of nursing materials management staff from having to kind of chase down that charge. And that's why we see that minimum threshold vary like we do. Hospitals kind of have a different idea of the cost that's not worth the time and resource of getting onto the patient claim, or if it's just going to hit a bunch of denials or something along those lines. So we do see that methodology employed here. Again, no right or wrong way, as long as you've got a policy in place that you can share if it's brought up. The use of fixed add-on and minimum charges really can compensate for those departmental resources for handling the supply, just like we see in the pharmacy area. Think things that need to be kept in a fireproof cabinet, things like that. Finally, we recommend creating that separate and distinct markup for the implantable revenue codes. So think 275, 276, 278. Those are your lenses, pacemakers, and implants. Many facilities have payer contract terms that are really sensitive in those items. So by simplifying the markup, that carve-out language and payer contract requirements can be simplified if you just kind of throw those into their own markup. Now, many facilities, like I said, many facilities should be charging based on cost, but many fall away from maintaining that relationship between cost and patient price because it can be cumbersome to update it, right? For example, we may establish a markup to determine the initial price of an item, but in the years to follow, we just apply that overall percent increase year over year. So as time goes on, things were set up 10 years ago are drastically different than a similar item that maybe that we set up yesterday. And because of this, the industry is really trying to move towards standardizing that supply markup to really reestablish that relationship between cost and patient price, which again addresses those compliance issues associated with those inconsistent charging practices. So we do recommend reviewing the Chargemaster for what would be considered non-billable supplies. And when deciding to remove those non-billable supplies from the Chargemaster, increase room rates, increase ED levels, operating room charges to kind of recover that revenue because that's where those items are being used. Now, just kind of demonstrating something here with the use of minimum charges. So like I said before, we see markups where if it's a low cost, it has a high multiplier. It's got a low cost, it has a low multiplier, right? So we have actually charted it out to demonstrate what this means, okay? So the chart on the left of the slide demonstrates how the use of markups that assign a lower multiplier to higher cost and a higher multiplier to lower cost looks when we graph it. So it's cost to patient charge. So you see this huge gap at around $1,000. What's happening here is the facility has a multiplier of 3 on items that cost between $300 and $1,000, which means that an item that costs $1,000 is being charged $3,000. However, if something costs $1,001, it's only being assigned a multiple of 2, making that patient charge $2,000. So now we've completely thrown off our scheme, right? In this situation, we're charging less for something that costs more. So although this markup is an industry standard, we have to be careful when we're implementing it to ensure that we don't run into issues like we see here. So by incorporating the use of a fixed add-on or a minimum charge, we ensure that we're charging more for items that cost more. So on the right-hand side, you can see how that line is continuous because we have actually plugged in a minimum charge at each of those levels where that break kind of happens. Again, this is just making sure the facility is charging more for items that cost more. So when it comes up, you can actually defend your markup. As I mentioned earlier, market data for pharmacy and supplies should not be analyzed at the HCPCS code level. Supplies is a great example. Those screws are used all over the place with the same code, and you're going to see a lot of variation in that market. Now, again, we're going to step back to that revenue code level. In this case, our screenshot here is focused on the 27X and the 62X revenue codes, demonstrating what supplies look like in this market. It appears that Hospital 17 probably has lots of pacemaker procedures, which is really driving up that revenue stream and would be an outlier, probably removed from this analysis if the hospital I'm working with does not do pacemaking. So tackling each of these areas to create a sound pricing methodology is really the first step in achieving our price transparency goals and improving that patient experience. These strategies ensure that prices are justified according to the Medicare fee schedules, actual costs, and that peer pricing data. Implementing these best practices can improve profitability by creating that justifiable pricing methodologies that ensure price transparency, price competitiveness, and earned reimbursement. Identifying those patient-sensitive and competitive items help the facility with becoming more retail-oriented. In the dawn of these new price transparency, not so new, price transparency requirements, payer negotiations, reimbursement analytics, and denial management are really going to become a primary focus for hospitals. So hospitals have to make sure they're doing several things. First off, I talked a little bit about it before, but that lesser of language. Your facility must ensure pricing is established in such a way to ensure your maximum revenue. So for some who maybe are unfamiliar, some managed care contracts include lesser of language, which limits DRG or CPT HCPCS reimbursement to either a published fee schedule amount from the payer or your billed charge, whichever is less. So if a hospital decides to reduce prices to become more in line with the market, they may inadvertently lose that net revenue because of that lesser of provision if they fall below that fee schedule. Now, since more patients are shopping the market for services, our recommendation is to ensure that the hospital's prices are in line with the average of the selected peer group wherever we can. After we find that average of the peer group at that line item level, we then compare that to any managed care fee schedules to really confirm that that market-based pricing is at or above those fee schedules to really ensure that hospital is getting that maximum reimbursement wherever possible. Now, as I discussed in the price strategies section, we prefer those charges be priced at a multiple of Medicare reimbursement. And this refers again to that OPPS payment rate. Now, a lot of my critical access hospitals will come to me saying OPPS doesn't matter to them because they're reimbursed based on cost. And that is correct. However, many times we find that they also have contracts, so third-party contracts that are related to those OPPS payment rates, and they get sneaky. They just put them in there. So for example, we had one facility that read reimbursement will be 3 times the Medicare OPPS rate or the current charge, whichever is less. But as a critical access hospital, they didn't even consider that the contract would be based on OPPS payments. So they were leaving money on the table. Additionally, and I think I've said it, this will be the 3rd time now, Medicare payment rates are intended to represent the cost of providing the service. So critical access hospitals should really keep an eye on what Medicare deems the cost, which is their reimbursement OPPS rates, to ensure that their prices are at least above those fee schedules. Now, private payers are going to set those hospital prices, reimbursement through that contract negotiation. And it's one of those things where we have to keep an eye on how we look in the market and how we can use this data to go against large payers like Anthem, United, that have armies of data economists to ensure that they're at the winning end of those negotiations. We need to make sure that we're kind of looking at that. Now, during negotiations, I always like my hospitals to know where they stand in the market, right? It's important when you're going to the negotiating table. It's important to know where I sit before I tell you where I stand. When we go into those, we need to arm ourselves with this data and understand how our market relates to us, how our payers are reimbursing us, and making those data-driven decisions. Now, modern reimbursement demands modern pricing structures, okay? Strategic pricing enables hospitals to align with fee schedules, minimize revenue leakage, improve transparency, and support those payer relationships. It is a foundational component of long-term sustainability, an environment where pricing accuracy directly affects your performance. Now, in a recent case study that we performed, we found that a traditional 3% increase produced about a $420,000 increase in additional net revenue. And so this is just focused on our percent of charge book of business, okay? So a traditional across the board 3% gave us $420,000. When we went back and we did a strategic redistribution model, we yielded $1.2 billion of additional net revenue. So what happened in this particular case where we were correcting underpricing, we were eliminating market outliers, we were improving reimbursement accuracy, and we were positioning the hospital more competitively. This analysis integrated fee schedules, hospital utilization, our market benchmarks, and contract terms, and our strategic adjustments increased underpriced items to the fee schedule amounts while reducing overpriced services. The overall Chargemaster movement was held to 3% per this hospital's contract terms. But by redistributing increases and decreases while remaining within that 3% limit, the hospital achieved nearly triple the financial return of a standard increase. So although this is just one example of the benefits of strategic pricing, we do see these opportunities across many of the hospitals we work with. And we encourage our hospitals to evaluate these strategies as they're looking at their annual price increase. So that's really it for the discussion. This is a tradition of ours here at HPS. We appreciate your time today, and as a thank you for joining us today, if you would like a free market pricing report for up to 4 of your hospital peers, you can take advantage of this offer by emailing Rick. The email, you can take a screenshot, I'll leave it here for a second, of this slide and include webinar HPS in the subject line. This offer will expire on July 3rd, let's say. Again, we'll give you that market pricing report so you can kind of take a look at how these strategies compare to you individually. And then let's see. Yeah, thanks again. This is our contact information. Faye Openshaw is our VP of Sales. She is excellent. If you ever have any questions or want to hear more about our services, you can reach out to her or me. Either way, we are here to help. Now, I think, Steve, you ready to answer some questions? And for those of you who might be shy, please send me an email. I am always open to have a discussion.
Great. Thank you, Randy. Great presentation. I don't see any current questions in the Q&A and chat, but some people did send me questions prior to the webinar. As you go throughout the country and work with hospitals, are you seeing hospitals integrate market-based pricing studies and strategies enter their budget process, since price transparency is something we really need to focus on?
Yeah, so it's funny. We thought that strategic pricing was going to fall off when price transparency became a reality. But since price transparency became a thing, many of our hospitals have really started paying closer attention to how their prices compare in the market. Now, at the same time, they still need to ensure that their pricing supports their reimbursement, that they're keeping up with that and remain above any fee schedules. So we've enhanced our models to really help evaluate those multiple scenarios within the budget process, whether that's consolidating pricing across campuses or developing competitive shoppable service strategies, really understanding how those pricing changes are going to impact payer relationships. Because again, it is part of, I mean, it's your income, right? When you're creating a budget, this is your income. And so what you're doing in that pricing realm, how you are addressing your pricing strategies is really important to your budgeting.
Good point. By the way, we did have a question. I think I know the answer, but I want to clear it with you. The presentation you just gave, can Chris send that to all the people that registered for this webinar? Or is that proprietary?
Nope, it's all yours.
Okay.
Yep, I will share. Go ahead.
Right. Here's another really good question. How do you really address reducing prices when managed care contracts have lesser of charge provisions?
Yeah, and I kind of cracked into this a little bit, but sometimes it gets confusing. So one of the biggest mistakes a hospital can make when they are trying to lower their charges to match the market is not understanding how that impacts their reimbursement. So some managed care contracts are going to have that lesser of language that limits that reimbursement either to a published fee schedule or the billed charge, whichever one is less. So if that hospital reduces those prices without really considering those provisions, it might inadvertently reduce reimbursement as a whole. So again, that approach is to first take a look. We got to look through two lenses, right? We're looking at that market pricing as that benchmark, and then we're going to evaluate those managed care contracts constraints and just make sure that if we are decreasing those prices, that we are making sure that we're staying within those reimbursement thresholds wherever possible.
Right. We hear a lot about transparency and machine readable files. Do you use hospital price transparency, machine readable files in your analysis?
So I will say we use them selectively, but they are not our primary source of data. So for example, we prefer to use the CMS claims data because it provides that obviously standardized way to really compare hospitals across the market. We know those are actual claims. The machine readable files can be valuable, but we found that sometimes there's some inconsistencies in how the organization publishes and maintains that information. That said, there are situations where that machine readable file will help me fill gaps in the Medicare claims data. For example, revenue streams like labor and delivery and nursery, those aren't going to be in the Medicare claims data. And if it is, it's not a patient that we probably want to compare against, right? So it may not be well represented in that CMS claims data. So I might tap out into a few machine readable files, maybe for a hospital's lead competitor or a couple of competitors in labor and delivery, just to kind of take a look at what's out there. Again, keeping in mind that there could be some inconsistencies in that data, but it at least gives us a little bit of additional insight.
Randy, as you know, Texas has quite a few rural hospitals and critical access hospitals. Yeah. Do you measure the impact of cost to charge ratios related to critical access hospitals when you do your review?
Absolutely. So because critical access hospitals are reimbursed on those costs rather than our traditional fee schedules, we do pay attention to how these pricing strategies are going to change that cost to charge ratio. So our models will actually assume that the costs remain stable. We know that that's not always the case, but we're going to take the conservative approach and we're going to say costs are going to remain the same between last year and this year. Prices are increasing, which means that CCR is going to go down, right? And this allows us to see that realistic view of how those pricing changes are going to influence that future reimbursement and cost reporting. Now, we know that critical access hospitals operate on very thin margins in those rural communities. So we are working closely with them to develop those pricing strategies that support that financial sustainability while minimizing kind of that unintended impact on that cost to charge ratio. So yes, to answer, yes, we look at that.
Here's a specific question that came in that a hospital wanted to know. We have experienced issues with using level charges rather than procedure-based charges, specifically in the OR. Can you use both? or how do you decide which one is best to use and best to defend?
That's a good question. So, yes, organizations can use either methodology or even a combination of both of those methodologies. And that depends on kind of your operational and financial goals. So, procedure-based charging in the OR generally provides really specific charges that are tied directly to a particular service performed. Whereas level-based charging can be a little bit easier to administer and maintain, particularly in areas where the procedures are going to vary significantly. So many of our hospitals will adopt a hybrid approach. They're going to use procedure-based charges for certain services and level-based methodologies for others. The most important consideration is just having a methodology that's consistent, well documented, and defensible. So hospitals should be able to demonstrate that they're charging the structure reasonably reflects those resources utilized and can be supported through that policy, their workflows, their EHR workflows, and that historical data.
Right. You know, Randy, when I talk to our member hospital CEOs and when I talk to many of the revenue cycle staff in our hospitals, they want to fully comply, obviously, with federal and state transparency laws, and they want to be as much in compliance around transparency as possible. So this is kind of an unfair question. As you've done work throughout the country, how has HPS seen it? Are hospitals lowering prices to get more in line with transparency, or are they raising prices, or is it too early to tell?
No, so that's interesting. We're actually seeing both. So in some cases, hospitals are discovering that they're significantly above the market, right? All those complaints actually are out there that we've been defending for so long, and they look at the market and say, "Oh wow, we are significantly above the market." So they are looking for opportunities to become more competitive. And then on the other hand, they've found that historically underpriced items are pretty much where they need to be. But the goal isn't necessarily to make prices higher or lower. We are finding that the goal is actually to make their increase more strategic, defensible, and aligned with kind of those financial objectives. So organizations are really having the most success using that transparency data to really make those informed decisions rather than reacting to kind of a feeling or a single benchmark. So we're seeing both, which is great, because we do want hospitals to be reimbursed and to price according to the services that they're providing and the quality that they're providing. And if the market can warrant that, then I think that's very valuable. It's very powerful for a hospital.
Another question is, how do you really model or even propose the appropriate transparency and pricing for what I'll call ancillary systems like pharmacy? Because they price items many times at the time of service.
Yeah, so ancillary services, so we're talking things that are priced on the fly, right? Some things come through the pharmacy module, or it's come through some sort of materials management module if people are still kind of using those. They do present some unique challenges during a pricing review, and it's because these prices don't actually live in the Chargemaster, right? So we actually use transaction data to kind of understand what's being charged. So we kind of step outside of the Chargemaster and dip into the trans to say, okay, what is the current pricing? What's actually coming through? And compare that to the peers. From there, we can recommend markup adjustments based on those goals. So, for example, a hospital may want to increase pharmacy markups by a certain percentage or bring that supply pricing more in line with market norms. So we also really have the ability to model pricing directly from that cost and markup data. So if you do have a pharmacy module that's using the cost and the markup, we can help kind of develop that strategic approach. I kind of talked about the fixed add-ons and the minimums and things like that. We can help lower those markups for things like self-administered drugs and create those methodologies for implants, pacemakers, lenses, stuff like that. So we really dig into more, kind of step outside of the Chargemaster and into the other data sources to really create that pricing structure.
Right. Well, Randy, I think you've really covered a lot of material in the hour, and you've answered a lot of good questions. And I'm glad you've still got the slide up where people can contact Faye or they can contact you if they have other questions or are interested in using HPS. But I'm going to give you the final word as we close out. Do you have any closing comments you'd like to make to our group?
Well, group team, thank you so much for joining me today. I really appreciate your time. I love talking about this topic. I'm super passionate about it. If you ever just want to have a chat, I'm always open to that. I love hearing kind of what's going on in your hospitals and making sure that we're meeting the needs of our clients. So here for you anytime. Let me know.
Thank you, Randy, and thank you for this presentation. And thanks to HPS for co-hosting and helping coordinate this webinar. At this time, we want to thank all of you for joining us, but we're now going to conclude this webinar. And everyone, please have a great afternoon. Thank you for being with us.